Good morning, everyone. Welcome to the third session of the IQSC Data and Analytics virtual event. My name is Teresa Mendoza, and I'll be helping lead the presentations today. We want to welcome everyone for taking the time to attend and be a part of these discussions, and we'll go ahead and get started. So let me see here. The first thing we want to do is thank our platinum sponsors. Our first platinum sponsor we want to thank is Stratascan, and we're going to show a short video for them. So thank you, Stratascan. Our next platinum sponsor was Untitled. We want to thank them for sponsoring this event today. We'll show their video. All right, thank you, Interlayer. And then our final platinum sponsor that we want to thank is Technion, and they're a big partner with us in supporting our data warehouse. So we'll show their video. All right. Thank you also to all of our event planners who helped with planning these events today. I especially want to thank my staff for all the hard work that they've done this year. Don't forget the posters. It's your last time to take a look at the posters if you haven't already. We've gotten several submissions on the poster survey, and we will do a drawing after the event and let everyone know who's won an Echo Dot or an Amazon gift card. So we appreciate UT Southwestern and PCCI and Parkland and there's one more, TWU. Don't forget TWU. And they're great submissions. We do have CNEs and HIMCEs. We will send out the link for the evaluations after this meeting so that you, for those of you who want to get CNEs or HIMCE, you can fill out the survey and we will send the certificates in the next 2 weeks. We are recording these sessions and we will make the presentations and the recordings available after the event. And we have no conflicts of interest. And if you do have a question, at the end of each, like at the end of the COVID-19 session, we'll take questions. You can post questions in the little question area and we will read them out to the speakers. With that being said, I'm very excited about our next data panel. And I think we have great presenters and a lot of in-depth knowledge of what happened here in the DFW area as far as COVID is concerned. And our first speaker will be Steve Love, who is the president of the Hospital Council. He has been working here for more than 10 years as our president. He serves on several boards, including the American Heart Association, Southwest Transplant, North Texas Eye Research, the Glaucoma Foundation, the YMCA. He's all over the place, even Mothers Against Drunk Driving. Mr. Love has worked in healthcare management for over 40 years, and he has demonstrated leadership in tax-exempt, investor-owned specialty and private hospitals, and we're very grateful to have him as the presenter today. After him on the COVID-19 panel will be Jacob Seil. I think I said that right. And he works for our the RAC, the North Central Texas Trauma Regional Advisory Center, and he has held the position of Crisis Communications Coalition System Performance and is currently the Emergency Medical Coordinator Manager. He was heavily involved in the Hurricane Harvey and Hurricane Laura, and now the COVID-19 pandemic. And he spent the last 6 months helping coordinate hospitals in the North Texas region with all the data reporting they've had to do around COVID-19 utilizing EM resource. And then our final speaker on the panel will be Dr. Brent Moran, and he's the Chief Medical Informatics Officer at Parkland. He has helped steward them from being a paper-based hospital to being fully electronic institution within 3 years. Quite amazing. And he graduated from UT Southwestern Medical School. He joined the General Internal Medicine Department in 1997. He is a dual board certified in both internal medicine and clinical informatics, being the second class to graduate with board certification in clinical informatics. In his role as CMIO, he's deeply involved in quality and safety projects, helping engineer and facilitating informatics solutions. So he's also, in April of 2016, he was humbled to be voted Physician of the Year by the Physician Academy Council. So we want to thank him for participating today. And with that being said, Steve, we're going to go ahead and get started with you.
Thank you, Teresa, and it's a real privilege and pleasure to be a part of this. And, you know, I'm going to give you kind of an overview from a hospital council perspective related to data and analytics. And Jacob and Dr. Moran are certainly going to show and demonstrate to you the data and the analytics and how it's used in operations. So it's a real honor to be on the panel, and it's a real honor to participate. We'll go to the next slide, Teresa. You know, I think many of you probably, it seems like many years ago, but on March 9th, we had our first case of COVID-19 in the DFW area. You know, about 3 days later, in Dallas County, a state of an emergency was called. And then on March 22nd, a shelter in place. 2 days later, Tarrant County followed suit. And then we realized in the early part of May that we had over 1,000 deaths from COVID-19 in Texas, and the pandemic was in full swing. Next slide, please, Teresa. You know, what are some of the actions we did here at the Hospital Council? And, you know, I give credit to the 90 member hospitals. You know, our hospitals, for the most part, certainly compete. Each wants their fair share of the market share, which is understandable. But at the same time, when they come to the Hospital Council, we're kind of Switzerland. We collaborate, cooperate, and work together with all the member hospitals, and they have really stepped up. They did it during Ebola, and they certainly have done it during COVID-19. We immediately started having CEO meetings, and we had system CEO meetings. And for those of you on this webinar that maybe aren't familiar with the structure of some of the systems, when I say system CEOs, I'm talking about people like Jim Scoggin from Methodist. I'm talking about Barclay Burdayan from THR, Dan Podolsky, Jim Hinton from Baylor Scott and White, Fred Cerise. I mean, these folks, we met weekly. We shared comments. We shared where we needed help. We shared things we could do at our board meetings. And my board is populated primarily by 15 key executives from our hospitals. And we had our board meetings and went through what strategically can we do. We brought together the chief nursing executives, and Sally Williams helped pull all of that together. What were the needs? Sally also brought together the human resource. You know, what kind of visitation policies are you going to do with COVID-19? What are some of the things that you're doing for the employees? What are some of the things so that we can do it in a collaborative fashion throughout North Texas? Patty Taylor did a great job of bringing together and working with a physician from Medical City on post-acute meetings. There was all kind of disconnects between when patients were discharged from our acute care hospitals. How would they go to a skilled nursing facility, a SNF? How would they go to an LTAC, a long-term acute care setting? How would they go back to senior living? What if they went to rehab? Each institution that was post-acute had a different set of rules, a different set of regulations. Parallel to this, we worked with people from EMTs, emergency management. We had people that were afraid to call 911. They were afraid to come to the hospital because they feared they would come down with COVID-19. And we had to explain to them that we took all kinds of precautions so that non-COVID-19 patients would not be commingled. And really the safest place you possibly could be when it comes to community spread would probably be to be in a hospital. I talked to cardiologists, and they had a 30 to 40% drop in some of the patients they saw. And we know that we didn't have a 30 or 40% improvement in cardiovascular disease in a 2 to 3 month period. We had people, unfortunately, when the EMTs would finally get there, after they finally called, they had more dead on arrivals. MedStar over in Fort Worth and in the Tarrant County area kept very good statistics on this, and it was quite alarming. So we brought all of this together to help be a facilitator to bring the different groups together. Next slide, Teresa. A lot of data and analytics. You know, the system shared their surge plans, their bed capacity, their PPE, their workforce, and God forbid if we had to do off-site capacity planning. All of this was instrumental in, at least from an operational planning point of view, we knew how many additional surge beds we had in North Texas if needed. Initially, March, April, and May, I don't mind telling you, PPE was hard to come by. Since then, we've done a much better job. But many people forget workforce. Dr. Moran and I were talking prior to starting this webinar today. Workforce is so important. You can have an empty bed, but if you can't staff it, you can't take care of the patient. So there was a lot of planning, a lot of looking at data and trying to analyze where we would go. Next slide, Teresa. What do we find out? And I mean this in a respectful way, not in any complaining way, but the federal government, the state government, the local counties, and the local cities all had different requirements. And all of them, candidly, were calling the hospital saying, I want this data. I want to know how many ventilators you've got. I want to know how much bed capacity you've got. I want to know how many ICU patients you've got. And we finally said, stop. We can't have this. You know, all we're doing is filling out government forms and not treating the patients. So we said, how can we bring this together and work collaboratively? Next slide, please. So what we did through cooperation, collaboration, and I thank all the data people and all the hospitals, and I want to thank the RAC, and you're going to hear from Jacob in a few minutes. We looked at the data users, we looked at the operations, we tried to facilitate the stakeholders. I would call the county, I would call the cities and say, look, if we can come up with a single source of data, can we do that so that we're all on the same page? So the lessons we learned from this is we weren't really prepared for a pandemic from a data point of view, from an analytical point of view, and frankly, from a clinical point of view. I give all the physicians and clinicians total kudos because they were flying an airplane and filing the flight plan at the same time. They had never treated COVID-19 before. They now know about steroids, remdesivir, so many other things they can do. They learned from New York, you don't put every patient on a ventilator. We've learned so many lessons, but data is key. Using the data, having a single source of data, sharing the data is so important. So after this is over, after hopefully we get a vaccine and COVID-19 is in the rearview mirror, we can take the lessons we've learned and apply this data so that we make better operational decisions. Thank you, Teresa.
Thank you, Steve. You know, we really appreciate Steve, you know, done a lot of work in helping coordinate, and he's been on a lot of calls every day, all the time with the cities and the counties and public health and just trying to keep everything coordinated for this area. And I think that because of him, we've probably done better than maybe some other states or other areas of the state because of his leadership. So thank you so much, Steve. With that being said, I'll turn it over to Jacob.
Thank you, Teresa, and good morning to everybody on the line. So my name is Jacob Seil with the North Central Texas Trauma Regional Advisory Council. And if we can go to the next slide, what I want to do is just spend a couple of minutes covering some of the key elements of the data reporting as it related to hospital reporting for the state and federal reporting requirements. To do that, I'm going to talk about who we are at the RAC, the role that we play, an introduction to EM Resource, which is the platform that was used for hospital reporting. I want to get into the timeline a little bit to cover some of this, the litany of changes that came down in state and federal reporting requirements. We'll take a brief look at some of the regional trends that we gathered from some of this data, and then some of the lessons learned and how we're going to use this data to, or really use this experience to improve how we collect data in the future. So if we can go to the next slide, NCTRAC stands for the North Central Texas Trauma Regional Advisory Council, which is a mouthful. We are anecdotally just called the RAC. We cover a 19-county trauma service area E, and that's going to be the 19 counties surrounding the DFW Metroplex. And our main mission is to promote and coordinate a system of quality trauma, acute, and emergency healthcare and preparedness in North Central Texas. So we do a lot on the day-to-day side. We host stroke committee, trauma committee, cardiac committee, all kinds of fun stuff along those lines. But we also do a significant amount of work in the disaster preparedness realm for healthcare, and that's largely based out of what's called the Hospital Preparedness Program. The Hospital Preparedness Program, or HPP, is a federal grant that funnels down from the Assistant Secretary for Preparedness and Response down to the states, and in Texas, that's Department of State Health Services that serves as the main contractor, and they break it up to 8 lead RACs across the state, and NCTRAC is one of those agencies. There's a lot of activities regarding planning and exercises that go along with this, but in the response realm, what happens is we get put under a state mission assignment for disaster response, and COVID is obviously the big one at the moment. And part of that state mission assignment includes our role as coordination with the hospitals on the required data submissions. There's a lot of education. Every time the state or the federal government makes a change to a data field, or they add new fields, remove old fields, change the format of reporting, anything like that, that's a large information distribution and dissemination mission from us. We also investigate the data quality issues and concerns. As hospitals are reporting, the sheer number of fields that are asked for daily lead to typos, lead to errors, lead to misinterpretations of certain fields, and so we track those down as we can. And I want to give a big shout out to UT Southwestern and their modeling team has helped us significantly in identifying data quality issues as well, that have helped us educate the region on how to better report data. And then we also take that data and we share it with our regional response stakeholders. We're not pushing it out to the public, but we do send out a daily dashboard to all of our hospitals, all the hospital leadership, emergency management, and city and county officials, as well as public health organizations, letting them know where we're at in the Trauma Service Area E region regarding COVID data. And if we move to the next slide, we'll go over kind of how that data is captured. And that's going to be in a platform called EM Resource. Now, EM Resource is a web-based platform. You log in on emresource.com. It's purchased at the state level off the top of that Hospital Preparedness Program grant, but it's got regional administration. In normal times, each region in the state of Texas has a lot of authority in terms of how they want to structure their EM Resource platform. We use it primarily for tracking healthcare resource status. So a hospital goes on and reports, hey, our ED is full right now. We're boarding patients. EMS, if you arrive with a non-critical patient, your wall times are going to be higher than normal. And EMS can use that information to make educated decisions about where to take patients as their protocols allow. And then also for the hospital transfer piece, hospitals can go on there and post what kinds of specialties they offer normally, what kind of specialties are currently available, and what kind of specialties they will never provide. So they can go on and say that our ICU is currently accepting transfers, but not for COVID patients because our COVID unit is full. They can say that we provide ECMO, but only for adults. They can say that we can do stroke neuro IR capabilities. It'll also list their trauma and stroke designations in that platform. Historically, we've captured bed availability data in monthly drills as a snapshot in time. So once a month, we'll send out a notification, hospitals, hey, please update your available staffed beds. Hospitals report that, and then those drills complete. The big thing is that this information, the bed availability information, historically has been intended for operational use. And what I mean by that is if you imagine a hurricane coming down on the coast and you end up with a lot of hospitals who are going to have to evacuate, they'll follow their normal processes and procedures to try and transfer patients as their internal plans call for. And then at a certain point when that's no longer viable, the state will step in and help coordinate some of these transfers. And to do that, they need to know the bed availability in each region. So they'll look at us and say, how many beds are available in Trauma Service Area E? We'll tell them, and then they'll send us a set number of patients. And then we use the bed availability reported by individual hospitals to help coordinate with medical direction and decide and help place those patients in the most appropriate place. But the key part of the system is that it's not inherently designed for large-scale data submissions. It is intended for you to be able to go in and update a particular status at a particular time. It's not intended really for hospitals to go in and report 100 new data fields each and every day. As an example of the limitation, you can't upload a CSV to EM resource that has all the information that's needed. You have to manually enter each number that needs to be entered. And that's caused a lot of consternation throughout this process because that makes it a pretty time-consuming reporting process. If we can move to the next slide, some of those issues the state and the federal governments tried to address through the introduction of new systems and new data elements. But what you're seeing on the screen here, this is kind of a timeline of the key changes that happened in the reporting requirements. So starting on March 18th, Department of State Health Services began asking for daily bed and COVID status reporting. At the time, this format was about 10 to 20 of these elements were reported in the survey-like format. And then the other elements were reported in EM resource in that manual reporting style that I just talked about. On the 24th of March, this became an executive order. And as you might imagine, compliance rates shot up. Generally speaking, prior to the executive order, we were only seeing around 50 to 60% of hospitals report per day. Post-executive order, that rose up to about 80%, 85%. On the 11th of April, HHS sent out a letter from Vice President Mike Pence requesting that hospitals report data in teletracking or NHSN. This caused a lot of confusion because most of the fields being asked for in teletracking and NHSN were already being reported in EM resource, but at the time, they still had to be reported in both places. On 4/20 of 2020, there was a major change to the reporting format. DSHS transferred all of the different data elements that were being reported away from a survey type format and all into EM resource manual element reporting. And this was also the first time that they released the data dictionary. And I want to highlight that because prior to 4/20, it was very difficult for some of the newer data fields. It was very difficult to get a very clear answer on what types of patients should be included. In terms of COVID-related ED visits, do you include only suspected patients, only PUIs? Do you include patients who were confirmed before they arrived? Do you include patients who you diagnose as COVID but they test negative? There were all these questions that really there wasn't a clear answer to right up until April 20th. And you'll notice that's a full month after most of this data started getting reported. Stayed pretty quiet up until the end of May, when DSHS actually began to implement an API to pull data from EM resource. So prior to May 30th, all the information that hospitals would manually report in EM resource, we at the RAC would take, aggregate up for our region, and then we would send that on up to the Department of State Health Services through a different platform called WebEOC. 5/30, that process changed. They were able to pull the data directly from EM resource, which gave the Department of State Health Services facility level data as opposed to region level data. On 7/13, Health and Human Services at the federal level sent a letter now requiring hospitals to report data in teletracking in order to be eligible for remdesivir allocations. This was probably the start of the biggest period of turmoil in all this. And the reason for that is that prior to this, some hospitals were reporting in both places, some hospitals were reporting only in EM resource, but a number of the fields that the federal government required were not located in EM resource at this time. So that changed on 7/22. This is really the big date when everything changed. You can see the number of data elements that were required to be reported jumped up from 61 to 99. And that was largely for the state to align with the federal reporting requirements, because what the federal government did was they allowed the state of Texas to submit data on their hospital's behalf. And the reason that this is a big deal is because when a hospital submits directly to teletracking, the state public health agency can't see that. They can't see the facility level data out of teletracking, which means that until the state can submit data for the hospitals to the federal government, hospitals were going to have to submit to both places because the state needed data as well. 7/22 was when that changed. We got the letter certifying from HHS that the state of Texas was eligible to report data for their hospitals to HHS, and all data reporting in the state of Texas flowed through EM resource at this point. There are still some issues along those lines. For example, HHS requires psych hospitals to report, but the state of Texas executive order does not require psych hospitals to report. And then there are a number of kind of minor variations in how data is captured. The state of Texas captures bed availability data broken up by specialty type, ICU beds available, telemetry beds available, med surge, ED, observation, all that fun stuff, whereas the federal government requires it as bulk number of available staffed beds. On 9/2, CMS issued an interim rule that now really stressed a lot of the hospital systems because it tied hospital reporting and non-compliance to potential CMS penalties and potential reductions in funding. As you might imagine, that was when we saw the biggest spike in compliance and reporting to where we're at now, where we have around 90 to 95% compliance in hospital reporting each and every day. And then on 1019, there were some new optional influenza fields added to the daily reporting requirements. Those are the big picture changes, but really there are a litany of tiny changes and small data definition clarifications that happened throughout this event that really, as much as they clarified, they also introduced confusion. For every change that was made to clarify one point, it was kind of a butterfly effect of rippling off and affecting more data fields beyond the initial one that it was fixing. And if we go to the next slide here, what we'll see is some of the major changes that took place on 7/22, and I really want to highlight that date because really some of the major key categories of data that we were capturing are not directly comparable from the data that was captured before 7/22 and the data that's captured since. And that's largely because of a couple of major changes in how those fields were reported. So daily COVID admissions is the first one that's pretty significant. Prior to 7/22, hospitals reported this in two fields. They said, how many COVID-related admissions did you have in the last 24 hours that went to an ICU bed? And how many COVID-related admissions in the last 24 hours that went to a med-surg bed? Now, after 7/22, that's 20 fields, and it's broken down by age and whether they are suspected versus confirmed. So each hospital every single day has to go in and report, in the last 24 hours, we admitted 4 PUIs that were between the age of 20 to 30, and we admitted 3 confirmed patients who were all between the ages of 50 to 60. But they have to enter a 0 in each field that is a 0, and that puts a significant burden on the person doing the reporting at the hospital. Another big piece of this, one of the key metrics that we've tried to track since the beginning and that has been difficult because of some of these changes, relates to the overall hospital census, and specifically the percentage of overall hospital census that are COVID positive. So before 7/22, hospitals reported their overall census as a single field. All patients, regardless of age or location, how many patients are in your hospital? And then there was a subfield for ICU, but those were not cumulative. Now it's 2 fields, and they report on inpatients only, and it is adult versus pediatric. And so that move to reporting inpatient only census is a pretty significant one, because prior to that, emergency department patients, observation patients, and outpatient beds, all those were included in the overall census. Now, post 7/22, they're not. And that makes it pretty difficult for us to have, again, a cohesive, from the beginning of March till now, timeline of what the overall occupancy of hospitals was and what the overall percentage of occupancy was that was taken up by COVID patients. And then the COVID census also saw a significant change. Prior to 7/22, it was 3 fields. It was reported as all your suspected patients that are in-house, and then your lab-confirmed patients that are in med-surg beds and lab-confirmed patients in ICU beds. And now it's reported in a much more broken down manner, PUIs by age, whether they're adult versus pediatric, and location, med-surg, ICU, or just overall surge beds. And then the same thing for lab-confirmed patients. So those were really the 3 biggest changes from 7/22 that affect the clarity of data and continuity of data from pre-July to post-July. Next slide, please. One of the key things that we focused on throughout this, and Steve referenced this as well, we tried really hard to eliminate reporting redundancies wherever possible. So to give you a little bit of an insight into how this looked, prior to about that mid-July point, hospitals were reporting separately to city and county government, local health departments, a variety of different interest groups, universities, the state, the federal government, all these different places hospitals had to report to. After about mid-July, that was when it really solidified where EM Resource was the key system for reporting. It was the single source of truth. Hospitals report an EM Resource and everybody else has access to that platform. And again, when I say everybody else, I really mean the response partners. We're not talking about the general public. We're talking about EMS, public health, emergency management, state and federal governments. And so that has really been, I think, a pretty big success in terms of relieving some of the burden on hospitals. It hasn't completely reduced reporting redundancies. There are still some occasional county judges or city mayors who will require ad hoc data submissions, but it's really reduced it pretty significantly. Next slide, please. So here, this is just kind of a brief overview, big picture, what we were able to track in COVID census and COVID-related ED visits. We peaked out on the COVID census at about 2,028 patients, and that was on July 21st. That was really our peak of that first wave, so to speak, and I'm throwing air quotes around it when I say that. But starting on 9/21 was when we started to see our second period of sustained increase. And since 9/21, we've actually peaked at 1,510 COVID patients, and that was actually reported 2 days ago on the 4th of November. COVID-related ED visits, that orange line you're seeing is the 7-day average of suspected and confirmed COVID patient ED visits per day. And we peaked on that at about 1,994 on July 14th. And most recently, and again, our second period of rise here, on the 3rd of November, we hit 1,633 is our most recent peak. So you can kind of see the overall trend of the COVID pandemic in North Texas just by looking at this graph. Next slide, please. This is the other one that is pretty telling for the impact that the pandemic has had on healthcare in North Texas. So this is at a 7-day average of the NEDOC score for the region. And NEDOC stands for National Emergency Department Overcrowding Score. So this is basically a quantifiable indicator of how busy an emergency department is. It tracks throughput, longest ED admit times, the number of ED beds, number of ED patients, number of critical care patients, and a couple of other pieces of data all come together to form that NEDOC score for each individual hospital. Hospitals in North Central Texas are required to update this data field once every 6 hours, and most hospitals are really doing it more frequently than that because they use it for internal planning as well. What you're seeing here is from 2019 to 2020, the 7-day average of NEDOCs across the region, the percentage difference between 2019 to 2020. So most year-to-year graphs that show this NEDOCs percentage difference, they look like the first part of this graph, where you see some periods of up, some periods of down. This is the first time since I've been at the RAC that we have had a sustained period of decline. And that period of decline really started on March 9th, and it ran through 6/28. That was 112 days where consistently our NEDOC scores were significantly lower than they were the year prior. And this is pretty important because one, it showcases the real major decrease in emergency department visits and overall healthcare census in most hospitals throughout the early stages of the pandemic. But two, this is the period where we started getting the most federal resources assigned to our region. And it was really the period where we didn't need them. We had the beds and the staff during the bulk of this period. It wasn't until we started hitting in about late June, early July that we really started seeing our COVID census and overall census rise to a significant enough level where we needed some external assistance. And the state was able to provide us with contract staffing in that regard. And then you can see it drops again from July 28th up until October 8th. And since then, we've seen a big sustained rise. And I want to point out that the peak that we see there in early October is significantly higher than the peak that we saw in July. And that's likely due to the fact that most hospitals are not only experiencing an increase in COVID census right now, but also an increase in overall census. Trauma patients are up, cardiac patients, stroke patients, all our normal patients are really on the rise. If we go to the next slide, please. So looking ahead, the big things that we want to take away from this and how we can improve this moving forward is focusing on planning, systems, accessibility, and automation. So better planning, we know what fields are going to be needed during a pandemic. I think that you could ask anybody who works in healthcare or emergency response that if a pandemic hits, we need to know how many pandemic cases are hospitalized in our jurisdiction, whatever that may be. But up until this, there was not one consistent way to report this data. Some regions did it in EM resource, the state of Texas utilized EM resource, the federal government utilized teletracking or NHSN, and then other states and different cities and counties used a variety of different systems. Since we know there are going to be common data elements, we really need to work to define those from the federal, state, and local level to make sure we have consistent data definitions before these things occur. Obviously, there will always be room for some flexibility depending on whatever the scenario is. But generally speaking, we know we're going to need to know available staffed ICU beds. We know we're going to need to know how many ventilators are available. These are common data fields that need to be built in to the normal kind of response operations pre-pandemic, so that when the pandemic hits, we don't have individual hospitals scrambling to try and figure out how to report this data in an accurate way. Better systems. So EM Resources, again, it's a good platform for what it is. But as we learn more and more about the data needs for a pandemic, we really need to identify a better system than EM Resource if we're going to be doing this 100 data field submissions on a daily basis. Either that or we need to make significant improvements to EM Resource. And that's actually a pretty key element of what's happened in the last few months. is Juvare, the company that owns EM Resource, has developed an API for hospitals to automatically update a lot of these data fields. It does require a significant workload on the hospital to set up how they're going to send the data over, but the API to receive the data has been built out, and we've seen some success with a couple of the hospital systems in our region, as well as others across the state. So accessibility is the other big thing. As mentioned, we know that all stakeholders have very similar basic data requirements. So we need to ensure that the systems we do have are built out to be accessible to those stakeholders. This is something that we'd focused on with the EM Resource in the past years. Personally, I've gone out and taught trainings to public health departments and city and county emergency management offices about how they can get access to the EM Resource and see some of this data in a non-pandemic. And now we've turned that on in a much more significant manner with the data sharing that we're doing on a daily basis. But beyond that, if the federal government is going to assign a particular platform for data capture, that platform needs to be accessible all the way through, from the state to the local, to the individual facility. And the reason that we need that is because without it, we end up having the redundant data requests that we saw in the early part of this pandemic and that are still to some degree out there. And then automation, I mentioned the API, but ultimately what we need to focus on is reducing the manual reporting burden. Every time we add new fields and every time that we change a definition of a field, it changes how hospitals gather that data. And so what we need to do is really focus on automating these systems, building APIs and building interfaces to ensure that the hospital EMR platforms and internal softwares that they're already using to track a number of these things. And at the higher level, a data warehouse that many hospital systems have. We need to make sure that those elements and those platforms can speak to the state and federal reporting platforms. That will reduce the manual entry, that will reduce the specific staff burden on hospitals, and it will ultimately lead to clearer and more reliable data. And that is the end of what I've got for y'all, so I'll turn it back over to you, Teresa. Thank you, everybody.
Thank you, Jacob. That was that was a lot going on, and we appreciate all the work that the RAC did in trying to coordinate and get these data fields. 199, I mean, it's almost 100 data fields. I mean, that's a lot to be manually entering and counting, and that's just, it seems like an enormous task that our hospitals have, taken on, and we appreciate all the work that the RAC's done to help coordinate that. With that being said, I am actually going to turn over my keyboard and mouse to Dr. Moran and give him controls and turn it over to him.
Thank you, Teresa. And excellent comments by Steve and Jacob, and Steve, certainly I'll second Teresa's comments about your leadership during this pandemic, and Jacob, those were some fantastic slides. I actually took a couple screenshots of them because that's some really good information there. I wanted to just kind of talk about a couple things that have been going on with Parkland, and so we've been using the RAC data a lot, and excuse the typo here, but we've used it a lot both to look at community infection growth rates, but also a lot of hospital capacity things, ICU ventilator, hospital census. We've looked at staffing pressures, and then the equipment and medication needs and responding overall to the reporting requirements, which I know Jacob touched on quite a bit there. So I'll talk a little bit about then what's been going on at Parkland. If I can go to the next slide, let me see here. Maybe Teresa, if you could move to the next slide, please. I'm not sure if I have control. Thank you. So not to reiterate what Steve said, but looking at the timeline, just to highlight, while the pandemic was going on, I think each of our organizations were scrambling, and so by early January of this year, our infection prevention team turned on the travel screening questions, and by February we were having executive leadership discussions about COVID potentially coming to North America. And then we declared a disaster at Parkland by the end of February, and we officially opened our command center a few days after that. That command center was staffed 24/7 until the beginning of September. And around that time, I think March 14th is what I say there, we had our first case of COVID. In fact, it was 3 cases at the same day. And then later that month of March, we opened our tactical care unit where we housed originally all of our COVID cases in a massive negative ventilation, negative isolation, negative air pressure unit, which was something that was a very helpful thing, at least from a staffing and PPE standpoint at Parkland. On the next slide, we talk a little bit about some of the things that we did from an informatics standpoint, and then I'm going to transition into what we've done with data. But from an informatics standpoint, a lot of what we did was kind of blocking and tackling, and we had to create a standing order so that people could order COVID from our nurse call system and from our triage. We had to do a centralized pool and a process for routing COVID results so that we could give people the appropriate answers of what to do when they had COVID. And that was a moving target, as you all remember, because what was the source of truth would change day by day, sometimes hour by hour. We stood up some screening, triaging questions at the clinic at the front door. We started sending out text messaging and appointment reminders that would cover that as well. And then interfacing outside organizations' labs into our EHR. What you see in the top left picture is the drive-through COVID testing, where we stood that up both at Parkland, and we also helped do it at some of the countywide testing sites. The bottom left corner, you can see our telemedicine cart, and I believe that's Dr. Levino, who's our medical director of the ICU. And you can see that he's in the COVID unit taking care of patients, and you can see that there are 4 other providers, and they began doing multiple times a day, multidisciplinary rounds on the COVID unit, so that a lot of the clinicians didn't have to go in, and we didn't go through a lot of PPE. But it was actually one of the first times where we had all of the specialists in the room seeing the patient at the same time talking, and it was actually much more efficient than the old school way of people getting around to coming and seeing the patient and dropping a note on the chart. The other thing, one of the persons who's on that telemedicine is our palliative care, and they were present in every single multidisciplinary call to ensure that the patient needs and the patient's pain and that the social aspects of the care were being addressed, which was a fantastic thing. The middle slide you can see is that we have, that's a COVID positive result, and we started sending those sort of like a critical lab, but not a critical lab, but we treated it as such, and we would push that through our secure messaging system. So the minute a patient would convert to positive, everybody who was signed in to the care team would get notifications so that they could make sure the appropriate precautions were being done and already were happening. And then the last screenshot there on the right is our COVID chat bot that we put on our website, which I think a lot of health systems did, which would help people screen themselves for COVID. If you go to the next slide, you can see a graphic of what happened when we, actually, yeah, the picture there, that's our Molly unit. That is our, we call it a Molly unit. It's kind of a Wally, kind of just a amalgam of machines put together, but basically it's a webcam on wheels. We call it the Molly unit, or Mobile Observation and Logistic Information Machine, and we would put those in the patient rooms so that people could communicate with the patients and check on the patients without having to go in and out of the room all the time and changing PPE and things like that. And so those were high definition, high resolution, audio visual webcams. They could pan and tilt. You could zoom in and look at the patient's IV and make sure that it was still infusing. You could check their IV site. It would auto answer when you would call the room, so you didn't have to teach a patient how to use it. And it was, we deployed over 150 of these throughout the organization, and it was very, very effective for letting the care team communicate with the patient and minimize exposure and PPE resources. So the next slide, we talk a little bit about what happened with our population health, and I'll be kind of transitioning to data at this point, which is when we started, as I think Jacob mentioned, when COVID hit in March, you can see the kind of red or pink line just plummet. and our office visits dropped by nearly 11,000 per week. So we had over a 70% drop in office visits, and it persisted through the next, through pretty much the summer. And we had a minimal footprint of virtual visits, which is our blue line. And you can see up until the pandemic happened, we had very little virtual care going on at Parkland. The green line is telephone visits, just to kind of show you kind of the control. And virtual care literally took off overnight and went up by over 900%, more than 9,000 visits per week. Overall, we've had in the first 5 months of the pandemic, 23,000 unique patients have received their complete care at Parkland via virtual methods only. And over 50% of patients have had one or more telemedicine visit as part of their care at Parkland. So that's something, maybe a ray of sunshine coming out of this pandemic, is it helped us really stand up virtual care in a very rapid and meaningful way. On the next slide, you can see what happened to the virtual visit breakdown for the clinics. Okay, so you can see this is just looking at clinic volume, both by absolute number as well as percent, and you can see that the kind of orange color shows the face-to-face visits. And you can see that we had, by and large, heading into, week 12 was kind of mid-March, and you can see we had about 60%, almost 70% of our visits were in person. And that quickly dropped to 43 and then 30 and a low of 26%, whereas virtual care just expanded, and we had virtual care up to 73% of our visits were virtual, particularly during the big spike in July when there was the surge in COVID. But the interesting thing, if you look at the bottom part of the graph, is our volume, and we were seeing about 8,800 patients a week, and this is in our primary care clinics, the COPCs, and it didn't really drop. It dropped maybe a couple hundred, but then it actually grew, and it went up to 9,100, 9,200, 97 and 9,800, and even 10,000. We actually grew business during the pandemic with virtual care. We were actually reaching out to and getting patients in for medical care that had been lost to follow-up because of transportation, social insecurities and things. And so where a lot of health systems saw major dents in their clinical outpatient care, drops of 40% or more, we were actually maintaining and growing services. And this was reflected similarly in our specialty clinics as well, where their numbers did not drop, and in fact, in some clinics, advanced. Interestingly, our show rates for virtual visits, when you look at that, which is not that surprising, but we've been able to look at, and our show rates are 7% better than our in-person, which would explain why we're able to kind of grow the business. And this year, with the pandemic, we've had over 250,000 virtual visits, and continuing and growing. Next slide, we look at an interesting graphic of just the virtual care, and you can see month on end, and I don't have to tell you what happened in March, but you can see how we had kind of a minimal footprint of virtual care, and then it has just massively grown. And it has fallen off a little bit as the pandemic has kind of settled down a little bit. We'll see what happens in the coming weeks. But it is a whole new era for us, and we are hoping to kind of maintain a foothold in virtual care because we do think there's value in that. As mentioned before, it will help us reach patients who may have some difficulties otherwise getting the care that they want. This is the current state of our virtual care. Like I said, over 250,000 completed encounters, over 260,000 unique patients. This is our dashboard that we have for tracking virtual care and some of the metrics we look at. We also look at what percent of the encounters had an ED visit in 30 days after having a virtual care. So is the virtual care serving a purpose, or are the patients ending up needing to come in anyway? And so we're looking at that within 30 days, within 48 hours. Just to see if there's an opportunity for us to make sure that we're addressing the needs of the patients. And the next slide. This is an interesting graphic PCCI created for us, and you can see these are the top causes of death for Dallas County. And you can see COVID, which was not on the radar, over time has gone up, and it is now the third leading cause of death in Dallas County per population, per capita basis, which is just scary and impressive, and just how disruptive that disease has been for this nation, for the world. Talking about data and talking about COVID, one of the big things that we did was we stood up a dashboard, and as we had our COVID command, we needed to make sure that they were getting the information that was readily necessary for them to manage the patients. So this is just part of the dashboard. I'll show you a couple slides about that. So this one, you can see that it shows a running total of how many positive COVID cases we have diagnosed at Parkland, how many have been discharged from the hospital, and then a breakdown by race, ethnicity, a breakdown by medical visit type, telling you how many have been hospitalized or ever hospitalized, looking at the death rate, and then also a breakdown by race, ethnicity for the death. We were very intentional in trying to look for inequity or any types of disparity. So we wanted to kind of stay on top of that. And then thanks to our colleagues at PCCI, we were able to geomap with the feed of all the COVID cases coming from Dallas County so that we could see where they were and identify hotspots and with the geomapping in this dashboard. The top of the dashboard is what I'm showing now, which was a lot of the logistic kind of items, such as how many patients do you have in the hospital in an inpatient or observation status, how many patients have come in the last couple of days of those patients, how many are admitted. So you can see kind of the dark blue line, and we have some patients, the tail that goes pretty far out. We have patients that may have been in the hospital for a month with COVID. What's the overall census? How many ICU beds are in use? How many COVID patients are in the ICU beds? How many vents are in use? How many COVID patients are in the vents? What's our mortality rate? The code HAPPY is a term we came up with to describe a patient who was discharged who had been COVID positive and admitted and hospitalized. At first, we would even play the song Happy over the speakers and announce the code HAPPY anytime a patient was discharged. And that kind of got old pretty quick, so they stopped doing it every time, and they did it twice a day, and now they've stopped that, and pretty much everyone's tired of the song Happy. But it's a neat thing, and certainly we celebrate when patients go home successfully. You can see that we also keep track of where the patients are, dashboard of where they are, and then the bottom of the graph shows the doubling rate and the overall volume of cases that we've had at Parkland. Moving further down in our dashboard, we get into in the left upper corner, we have looking at, as we look at admissions, patients in the hospital, in the ICU, and on the ventilator, and you can see the running graph, and this pretty much emulates what Jacob showed, and just on a smaller scale at Parkland. But we also have a widget over here where we try to show what we think are the predictions and the projections in the next 7 days using some kind of modeling that we've done with the PCCI playing lead role in that. So how many patients do we think our peak census may be in the next 7 days, and how many patients do we think are going to be in the ICU in the next 7 days? And nothing's perfect, but these have been relatively accurate. And I'll go into more detail in our modeling in a minute. And then we have our length of stay, and we can see we track, and we can see the trend. If it's red, that means the number's getting worse. If it's green, the number's been getting better. And then we also are tracking the length of stay historical trend. And then the bottom of the dashboard covers the lab aspects of it. So what is our overall positivity rate for COVID testing? So all comers who get tested had a 14.7 positivity rate for the last week. And you can see the trend of how that's going, and it's going up. We also see turnaround time for the labs, because that's something we're very attentive to. So, and how many hours is the turnaround time? And you can see that the vast majority of our COVID tests have a turnaround time in under 2 hours. And then we have a intermediate test, which is the Roche test, and then we have the ARUP, which is our send out that we do for most of our drive-through testing, which has about a 1.5 day turnaround time. And then when we go back to looking at the positivity rate, we break it up into asymptomatic screening versus symptomatic, and infant of a COVID positive mother. And we break down those rates as well, and then we trend those out. And so you can see all of these rates have been going up. The asymptomatic rate has been going up, the symptomatic rate has been going up, and then the infant of mother baby has a very small denominator, so it's all over the place. We break up where the tests are coming, so you can see where the labs are, which labs are we using most, and that's been a moving target as with all organizations because of the supply-demand issues. But it's been very helpful from a tactical standpoint for the COVID command and the leadership. This is what our current prediction model looks like, and we went through a lot of different iterations. And again, PCCI, Parkland Center for Clinical Innovation, under Steve Miff and his team did a really good job of helping us with that, and Vikas Chowdhury and took lead on that. And we started with a model of looking at kind of low, moderate, and high, with the high actually being what the pandemic of flu was in 1918, so worst case scenario. And as with everybody, nobody knew how good or bad this pandemic would be, and some models literally were showing 5,000 patients needing to be admitted to Parkland in one day at the peak, which would just be insurmountable, and just it would be a tsunami. And so we were scared, everybody was scared, and so we were working on modeling. And so we had a low, moderate, and high model, and with the moderate and low based on kind of some China early data that had come out. We later moved to an international versus US model, with the international mostly representing kind of the Wuhan experience with a little bit of Spain thrown in, and the US model kind of representing mostly Seattle, which had gone ahead of us and had a lot of similarities to Parkland and how we looked like we were going. And then most recently, we're going with a kind of RT model, or the infectivity over time, kind of an R naught, but it's not, versus mobility. And we've looked at mobility modeling, but mobility, as you all have seen, had some early benefits with prediction, but now, as most people are mobile, but they are wearing masks and they are doing social distancing, it's not as predictive. But the RT has actually worked quite well. And if you look at, well, actually, I'll show that in a second, but also the other things we have on the dashboard is we have a PPE burn rate prediction model, and we also have a staff surge model. And I'm showing the staff surge model, which Dr. Eugene Hsu, the chief of hospital medicine, helped created single-handedly, essentially. But it's very helpful because it's color-coded, and you can see when it gets into the yellow, the volume of cases that the teams are taking care of is starting to stress them. It's starting to get to the upper limits. When it's in the red, it's getting to the point where the team is having a difficult time, and it's kind of beyond what they feel they can, or it's at the limit of where they feel they're kind of about to reach the limit. And so it's very useful to look at this so that we can make sure, and when that happens, we can work on decompressing those teams or providing assistance and mobilizing other resources to help. And so this has been a very useful model and very beneficial. Getting back to that prediction model, you can see the purple line here in this graph is reality. This is what really happened. The green line is the RT model, which is kind of the R naught over time, predicting how the infectivity goes. And then the jagged line is the mobility model, where we would re-up and redo it every week to reset and level set it. And you can see that by and large, the reality followed the RT model quite well. And that's been the thing that we're using at Parkland. Getting back to value from the RAC data, there's been a lot of value both to Parkland as well as to the community. And looking at just kind of mapping out the 7-day moving average of admissions week on week, and you can see as things were going up, what were some of the decisions. But you know, with the stay home based on when there was a big spike here, you can see the significant changes, which are likely due to everybody getting kind of the right messaging. And so there's been a lot of value with the RAC data and kind of showing the data and having data-driven decisions as far as what's the safe thing to do for the community. So that's something that we're very thankful for. So I wanted to pivot lastly to just talking about some proximity initiatives that we've done with data at Parkland. And one of the things we've done is we have looked at, as I said, PCCI has geomapping and hotspotting, and they have capabilities where we can map out where COVID is. And so we started talking about how we can use the data. And one of the first things we said is, well, we would want to know if someone lives near someone else who has COVID and that person is coming in for an appointment at Parkland, we'd like to know so we can screen them. And so we started what we call the proximity initiatives. And we started out just saying if someone lives within a quarter mile of another person with COVID, put them on a report, and we'll have a group of nurses call them and triage them before they come in. That quickly became a massive number, so we dropped it to 1/64 of a mile, where I literally got onto Google Maps and figured out what's a 4-house radius, and it ended up being about that. And what we would do is we would create a report that looked at people who lived within this distance of people who had COVID. We would push that report into our EHR, where we would go to a pool of nurses who would call the patients. It would be if they had an appointment in the next 1 to 2 days, and so we would do that 3 times weekly. But then PCCI got more intelligent and actually created a predictive analytics algorithm based on that, and it's very I won't go through the math with you because I can't, but basically it looks at the diameter of the 3 closest COVID cases to the patient who has an upcoming appointment, divided by the total number of cases in their block group, and it gives them a ratio, and then it assigns them whether they're high risk or not. And so again, you can see that the proximity initiative, again, we would call them, we triage them. If they had symptoms, we would set them up for a virtual visit or reschedule. If they didn't have symptoms, they would receive usual care. We also embedded that proximity score into our EHR so that you could see it as you were looking at the patients, and you could see who had high, and you could make sure that they were being triaged. We would likewise push through if they had COVID, both at Parkland or from outside of Parkland in the health system. And then we built in some decision support. So this was the kind of thing that the screeners would see when someone would walk in, and if they were high proximity index, if they were a patient coming in for an appointment, or if a clinician was opening the chart on a patient, it would tell you that they had a high score. Not for the point, because we screened everybody for emerging pathogens, but this was an opportunity to tell them you live in an area where you may have higher risks, so be sure and wear a mask, wash your hands, socially distance. It was more of a learning opportunity for these people. Likewise, with the triaging, we baked it into our EHR so that depending on what was chosen, it would actually give the nurses recommendations on what to do. So that was baked in. So how did the score do? Well, we screened over almost 750,000 encounters to date with that score, more than 163,000 patients, and this is just a breakdown of what the patient demographics are. But it was very interesting, and there's been a couple iterations. You can see between June and July, PCCI worked on optimizing the prediction model a bit. But since that time, for the last 4 months, this prediction score has been able to identify between 14 and 16% of patients who would admit to COVID-like symptoms. So if PCCI marked them as a high proximity index, about 16% of them. Now, on average, it was 11%, but lately it's been about 15 to 16% would endorse COVID-like symptoms. Likewise, if we asked them if they had been exposed to someone with COVID, between 21 and 32%, so up to a third of patients would admit to a COVID exposure. And again, the running average is 18%, but with the new model, it's been a lot more, much more accurate. And then if they did get tested, 20% of them were positive. So 1 in 5 patients who were identified as high proximity index ended up having a COVID test. So this was a very valuable risk score or index score, and we were able to use that to help identify patients who may be at risk who are coming into the health system. So the next thing we did is then we turned around. Wow, these slides kind of didn't convert over very well. Sorry about that. But at any rate, we started turning this outward using the same risk model. We started looking at patients who did not have an appointment in the coming month, but who had been seen at Parkland in the last year. And because the volume of patients was so high, we didn't have the manpower to call them manually by nurse. And so what we started doing is sending them an automated text survey and asking them to fill it out and asking them COVID-like illness symptoms. And if they admitted to having COVID-like illness symptoms, we would then go ahead and screen them for medical needs. Do you have any refills you need? Would you like to see a doctor? And if so, we would set them up with a virtual visit, because we would not want these people coming into a health system unless they were critically ill. And then we would also screen them for food insecurity, because food insecurity is one of the biggest social needs with this pandemic. And we have partnered up with a couple food banks who will deliver food to these people who are struggling during this pandemic. And so it's a pretty neat initiative, and we're just kind of early in the phase, but we are looking at over 400,000 patients that we've seen, and we're working through kind of screening them and triaging them. With this, we're looking at, with this outward-looking initiative, we also didn't want to just screen everybody who may have COVID, because young, healthy people may have COVID, but they're going to do okay. So what we wanted to do is look not just for people that have a high proximity index, but also people who have a high vulnerability. And so PCCI created a second index, which is vulnerability, which looked at comorbidities, social determinants, age, as well as lockdown adherence. And then they created a new risk model, which helped us kind of narrow down the number of patients that we would be triaging and screening. And then the last thing we did with the proximity is kind of the third initiative, which is community engagement. And we worked using those geomapping and hotspotting and the proximity and the vulnerability indexes. We would work with the community partners to do educational campaigns. We would do robocalling and text messaging to specific zip codes or block areas. And to date, we've done over 100,000 robocalls and 200,000 text messages. We have community health workers who've had over 3,000 encounters with people to help them with a variety of things, including education and social and medical needs. And so it's been a big success with that. And we're using some mobility highlights to be able to see where the mobility is going as far as where the pandemic has been and where it's headed. We're able to use the vulnerability to look at and where are the vulnerable people, where are the hotspots for COVID, where are the testing sites, and where do we need to do outreach, where do we need to do communication, is there a need for extra testing sites and things like that. And then we're moving that, expanding that to school-age children, looking at outbreaks in schools, and we're looking at influenza. How can we look for outbreaks of flu that's going to worsen with this COVID pandemic? And so we're looking at, the first part of that is to make sure that people who need a flu shot get vaccinated. So we're looking at geomapping. Again, this is from PCCI, of people who had flu-related hospitalization, who did not get the flu shot as much as other people, and where are the high-risk patients. And so that helped identify where we need to vaccinate patients. And then this is where we are vaccinating patients. And so we're trying to make sure that we have emphasis at Parkland, as well as with our community partners, in vaccinating the patients who are most vulnerable with this pandemic going on. And then we're keeping track of our resources through some databases as far as how many vaccine vials do we have, how many are we using, and things like that. So to date, our vaccine, we're tracking how we're doing. This is 5 years of giving flu shots at Parkland. You can see the big spike, usually a little over 8,000, 8,500 vaccines in our peak week. And you can see this year we're a little bit behind. It's a little slower uptake with the pandemic. People aren't as inclined to come to the doctor's office or go get a shot. But we're hoping to have as good or better uptake with the flu vaccine. So acknowledgments to a lot of people who took part in this. There's a lot of partners, both with Dallas County, the city, PCCI, and a whole lot of people, many more who aren't even listed on the screen. So I'll stop and thank you for the time and the opportunity.
Thank you, Dr. Moran. I need to apologize to him because he had sent me updated slides where he had corrected his COVID misspelling. And not only did I not insert the right slides, I accidentally inserted it into the NetRec template. So I promise you when I upload them, I'll have them in the correct template and the correct slides.
That's all right.
So with that being said, we are opening up for questions. If anyone has questions, and we already have one. It says here, what methods were used for patients who have health literacy deficiencies? What was your outreach for them? I assume that's for you, Dr. Moran.
Yeah, so that was a great opportunity for our community health workers, both to directly navigate with the patient, but also to work with the community partners. And a lot of our community partners were the faith-based organizations who have great networking, and who a lot of these people in the community are already members of or partners with. And so we would help work with them to provide education, supplies, even some PPE and those kind of things. And then they would help disseminate that out through their organizations.
Okay, great. The next question is, since school has started, have we seen an uptick in COVID? What is the outreach for Latino families that live with multi-generations? Whoever would like on the panel to take that.
This is Steve. I will say this. In looking at children's census, both in Fort Worth and in the Dallas area, the hospitalizations related to children since school has started has not gone up significantly. What I can't answer is how many people have tested positive. I do know that for some of the procedures done at the children's hospitals where they did the asymptomatic testing, it did not go up significantly. But Dr. Moran may have much better clinical answers than that.
Yeah, you know, I agree with Steve. I mean, we have seen increasing rates of COVID cases, particularly originally in the 5 to 13-year-olds, and now the 14 to 17-year-olds are going up. There are some increasing cases, and they have gone up since the schools have opened. As Steve said, hospitalizations had not originally spiked. There seems like there may be a spike coming post-Halloween, but and what mostly we're finding is it doesn't seem that these infections are happening in the schools. It seems to be more social gatherings that may be post-school activities or even family-related things. And most of it seems to be outside of the actual schools themselves.
So the second part of that question was, what type of outreach is being done for, like Latino families that have multi-generations living in the home? Is anything?
Yeah, that's the difficult thing. Again, we're trying to work with the community partners, and number one is to make sure that everyone gets vaccinated, if at all possible. And so we're working with some of the media, the television and radio companies as well that are to help get advertising out, and also with some flu drives that the county is doing throughout the city and the area. But as far as if someone in their family gets flu, we are kind of recommending that they try to isolate, particularly the elderly and the vulnerable, away from the person who has flu or COVID, and that they make sure and try to, if possible, to minimize exposure, to try to use a different bathroom if they have more than one bathroom, and if they need help, to ask for resources. And there are some resources, again, from community partners as far as helping in these situations.
Okay, well, we've got feedback on everyone's enjoyed all three of you speakers, and excellent job. I don't think we have any other questions at this time for the panel. So I will make sure the correct slides get uploaded for Dr. Moran after this conference, and along with all the other slides. And we appreciate the three of you presenting today on our panel. It was a great job and a lot of great information. And Parkland's doing some very innovative, creative things, and I hope it's something we can continue to learn and spread throughout the community. Oh, I do have one. Okay, I have, Albert Karam from, I don't know if I'm saying the last name right, Albert, from PCCI says that the proximity, vulnerability, and influenza work is also on 2 of the posters that we posted out there, if you haven't had a chance to go look at the posters. And then after today, we'll be cutting that off so we can do the drawing.
Yeah, and PCCI has a lot of these geomaps are publicly available on the website, on their website, where you can see those things. So that's another place to go for resources.
Okay, well, thank you very much. With that being said, we will go ahead and close this panel and get started on our next presenter. So our next presentation is from Michael Paris. He's the VP of Data and Analytics at Texas Health Resources. So we're excited to have him talk about data governance, developing an in-house data science capability. And Michael has over 16 years of experience as improvement and analytical leader with a strong focus on vision planning and execution. He's a hands-on leader and develops his people across the organization. He has played a key role in defining and achieving strategic initiatives for improving physician relationships, blood utilization, order set usage, medication reconciliation, advanced directive, and population segmentation. So, Michael, with that being said, I'm going to turn it over to you.
Okay, thank you. So, what we're going to focus on today is kind of how you build an in-house data science capability and what kind of are the right steps and wrong steps. And I'm not certain how to advance the slides. I thought you were advancing them.
Yeah.
Okay, thank you.
I can just say next.
Thank you. So what we're going to do is the contents of this are really kind of understanding your current state. We're going to step through how you kind of create a roadmap, what to kind of look for in developing your job descriptions and your organizational structure, developing kind of your internal resources, and how you can kind of plan to grow things out. So if you go for the next slide. Okay, so when you're looking at your current state, and this is a very busy slide, so forgive me on this one, but understanding your current state is a very important piece. And that first part that I put up there, which is what does your leadership understand? This is key to any starting of a data science team. Does your leadership really understand the difference between general analytics and data science? Do they know that data science is just not something you can add to an existing team? Have they understood that data science is not just one thing? It's really a whole slew of techniques and tools that you go through, which I kind of illustrate by that the Gartner hype cycle over to the side, where you have anything from text and predictive analytics to graph analytics to synthetic data to machine learning pieces, all those things, supervised or unsupervised learning. Each one of those are different techniques. And what does your leadership understand and what do they not? And I'm not saying you need to make your leadership understand what each one of these things are. Good luck if you try that. It's really more of letting them understand that we have to pick a focus and what we think we're going to be doing good at, because we cannot do everything. Because if you try to do everything on this list, you better have a budget above 10, 20 million to actually do it. And most of us that are starting off building a data science area are not going to have that sort of budget. One other way to kind of look at this is, when you're talking with your leaders, understand what vendor presentations they've seen. Have they been sold something that's been maybe failed in the past or tried something before? Understand that kind of current state of where their knowledge is from that perspective. A lot of what vendors show them is something that, hey, we can turn this around in 3 months and you can have something working. But the actual thing is, yeah, it works, but it's typically patchwork through, and you're going to have to then productionalize it, which still takes additional effort. Make certain that they understand that, developing that model is actually, sadly, the easiest part of the work. It's actually the productionalizing and maintaining that model and retraining that model that really takes a lot of the effort. Does your leadership even understand that when you build a kind of a model, that those models actually degrade over time for most of your predictive models and ML model sides of things, and that they'll require maintenance? When you're productionalizing that models, do they understand that's where most companies fail, and that's where it requires more than just fancy data? Once you actually have a model built out there, and I'll give it my own personal experience, you have to have someone to act on that model. In a past role, we developed a predictive model that said who was going to have a heart attack out of a population of like 200,000. we picked about 1,000 people that we had predicted were going to have a heart attack in the next 6 months based off their use cases. Someone had to act on that data once we knew it, and that whole productionalization side of it, management has to realize someone needs to act on that data, because we delivered that data and no one knew exactly what to do with it, how to contact the customer and say, hey, our algorithms are telling us you're going to have a heart attack. We'd like to get you back on your medication, which you seem to have not been refilling. They sat on the data for about 3 months, and when they started calling, about 70% of the people were already in the hospital for a heart attack. These are things where you really have to have someone who's ready to act on the information you go. Next piece is, do they kind of have a focus? Do they know a general area that they're going to want to work on? Because without that kind of general focus and kind of a common understanding, it's really hard to set those realistic expectations when it comes to the whole budget side, when it comes to the time frame side, because is this a 2-year project? Is it a 6-month project? Is this a series of projects that go over 2 years? Where is that kind of building part of things? And it also makes a difference in what tools you might need. Are you trying to deal with streaming data? Are you able to do a batch job on a monthly basis and put that recommendation out there so that it can be ran by a different tool? How is this really working? The other area that you really need them to help you focus on is, what area do you want to play? Do you want to play in imaging? Do you want to play in the clinical predictive side? Do you want to play in the marketing side, the strategy side, supply chain, location planning side, finance, patient experience? All these require different techniques and different tool sets depending on what your use case is, and it can make a difference on how you want to set up. Go forward once. Okay. Next, that you want to be able to do once you've kind of got the that understanding of where your leadership is, you really need to be evaluating what internal skills you have. And some of the first places to kind of look is, what do your data engineers really do in the organization? Do you even have those? Do you have statistical analysts anywhere? Or are most of your analysts people who are pretty good in Excel and kind of bumped up into an analyst role? Who has SQL skills in your analytic area? You'll find a lot of analysts have really good Excel skills, or might have some pretty good, VB sort of programming schools where they're making macros in Excel. But you might find 1 or 2 of them out there that really like to use Python or R. Or you might even have some people that are using another traditional machine learning tool, such as SAS, SPSS. There's so many of them out there that I could spend half this call just naming all the tools. So, but when you're looking at it, it's really a question of setting it up. And this is where you have to kind of decide, do I want to go down the full data scientist path, or do I want to go down the citizen data scientist path? And the reason I say this is the tools are different for both of those. Some of your citizen data scientist tools have guardrails that tell people, hey, your model's kind of overfitting, you probably want to check your data. Some of them really kind of give those, holding hands to get through. And, the traditional data science tools, they really expect you to understand what you're looking at and be able to make those calls for themselves. That's an important part, to be able to understand your current state. Which direction are you going? Citizen data science path or the full data science path? Second one is, and this is my suggestion, utilize R and Python. They are free open source tools. They're desktop versions. You can actually even set up a server version of Anaconda without really having to pay too much licensing fee. You're really just paying for the server and the maintenance of the server. Those things, and that's assuming you don't already have a ML tool out there. But if you do have an existing ML tool, some of the things you do need to look for is, look at the number of license seats you have. What's the server size on it? Is it really going to meet what needs you have? Because I'll tell you, when you go down that machine learning tool side, most of the time you're looking at, for an average size setup, somewhere above the 350,000 on an annual basis. And typically you're going to go pretty quickly higher than that cost when it goes. The other piece is you need to be able to talk to your internal teams from your data center folks. If you guys have a data center, is everything you're doing in cloud, or is it have to be on-prem? Since we're talking to a mainly healthcare group here, I would say a majority of your guys' stuff is still on-prem, and that's not that bad of a thing. You will run into your own set of difficulties there, but typically your cost on-prem, at least over a 3 to 4 year period, does end up being a little bit cheaper than going into the cloud. However, when you're in the cloud, there's lots of advantages, and that advantage is, first off, in my opinion, is Kubernetes. For those who aren't aware, Kubernetes is a different way of setting up servers, and it really allows you to basically containerize your program so you can load multiple programs at the same time. But it is a new thing to most data center folks. It is not something that they have been exposed to typically. You might be luckier than I have been in the past, but if you're dealing with a Kubernetes platform, cloud's typically the way to go because you can set it up quicker, but you will incur cost in the long run. One other piece that I would say is, while I'm pushing you down that R and Python route, you need to make certain you have your IT governance approval to use open source software. Sometimes that's a little bit more difficult in some organizations than others. And the other piece is start with desktop versions. If you have some pretty good analysts in there, they can figure out the right sampling method to still do most of your basic predictive models, the stuff you're going to do for that first 6 months to a year inside their desktop, and then you can expand out to the server versions in about 6 months to a year later. And this is all about kind of building that roadmap that you're going on. If you would, go to the next slide. When you're creating your roadmap, you really want to understand what your company's possible use cases are. Here's the hiccup on that side. If your leaders don't understand what data science really is or what possible things are out there, they might not actually know what can be done. And so your job is kind of to be listening to a lot of their problems and then start talking to them about opportunities with data scientists, data science work, and really kind of selling those options. This is another example where you can actually listen to what they're being pitched by a lot of vendors. And depending on what that vendor's pitching, you can say, well, yeah, we have this capability in-house, and honestly, we have the data in-house, so it makes more sense for us to try and do it internally. Or no, this vendor's really bringing something new to market. And that, to me, is one of the key pieces that an organization does need to set up, which is that center of excellence that for data science, which helps different leaders across the organization evaluate predictive models, data science tools that vendors are bringing in. One, it gives you an idea of what people are looking at, but two, it also gives you an idea of, hey, is this an opportunity for my team, or really does this vendor bring something new? Or a couple times we've listened to some of the vendor pitches and we've looked at it and gone, you know what, they're actually not doing what you think they're doing. This is not worth the money that they're asking for, and you're probably not going to get the results that you're wanting to out of it. And these are good advice you can give to leaders and be able to slowly build that camaraderie and that structure where they begin to trust you more and more and will bring projects to you. So when looking at this, you really do need to understand the general type of data you're working with. I can't stress this more. What you're buying from a tool perspective makes a difference on what data you're using, especially if you're going down the imaging route. It's a completely different setup you do for a lot of your tooling and your hardware side than what you would do if you're doing just general predictive models and that sort of side. If you're doing real-time data, that is, to me, something you shouldn't attack right away. Unless that's going to be your only focus for the next year and a half. You really don't want to start off with real-time event stream data. Not saying you can't do it, I'm just saying it wouldn't be the place that I would first start. That comes down to the next statement, which is don't try and do everything. Pick one or two in the beginning. Look for things that you can do in a 6-month time period or less. And I do mean you want to be not just develop a model in 6 months, but be able to implement that model and have people react. A great place that I've found is pretty easy to start is the marketing side of the business, because if you can give them segmentation and propensity models on top of their marketing campaigns, they can act on those things very quickly. It's not something that's needed in a real-time basis, but it is something that builds momentum for you as the organization. Supply chain's a great area as well, as to be able to build some predictive models. They take a little bit longer to implement, mainly because, you know, they're trusting something new, and if we run out of stock, it's a little bit more of a problem than if a marketing campaign gets off a week later or starts a week early. One other piece, I can't stress this enough, avoid fully automating real-time machine learning on your first projects. That's something that's you're going to grow into over time. The other thing is, as you're building your roadmap, you should be building out that coaching and training of leaders in what data literacy and data science is about. And I say you have to do that together, because a lot of the things that people are learning about data science really has a backbone in data literacy to say, what does this actually mean? When I'm looking at this chart, how does it make sense? And you want to decide, who do we train on those areas? Is it starting off at do we just focus on the team that we're going to be working with as far as training them how to read the charts, how to utilize the information? Or do you need to start up higher in the organization? And to me, the levels of information people need really depend on the use cases that you're working on. And I'd love to give you a hard and fast rule, but to me, it's one of those answers that just depends. If you would select the next slide. When you're kind of looking at it from a roadmap perspective, and I once again grab this from Gartner because I think they do a pretty good job of stepping through this. People have to realize, and this is part of that data literacy and learning for the organization around data sciences, there is a life cycle to these things. And as long as you're continuing to use a model, that life cycle continues. And it basically works through this kind of figure eight thing. You really do kind of have to plan for maintenance, and we'll just kind of start through it. The business understanding, this is that first step where I'm saying, you have to talk with your business, really understand what problem they're trying to solve. And I will tell you, that's going to take a deep dive, longer than you would expect when it's your first project working in an area, because people aren't going to understand what you can do with the predictive models, how you can use them, or what you can do from a data science perspective for them. The next step is really that data source discovery. If you haven't had an enterprise data warehouse team that's been curating the data and strong data governance and say, these are the sources of truth for this information, you're going to spend a good portion of your time, probably 30% of your time in the beginning, just really kind of doing that data discovery and data wrangling that comes through, where you're basically moving the data into the right sort of format so that it will work for the model. In the beginning, you're going to be doing that kind of on a manual basis, but you need to be planning for automation on how you're doing the data wrangling, because once you've done the data wrangling once, guess what? If this model works, you're going to have to do it again and again and again as it goes through. Next step is you're really kind of doing that analysis where you're doing the model and testing and development. Quick check for most vendors when you're talking with them is understanding how they're building their training set data and their test data. You'd be amazed at how often they don't have a large enough training set or test data, and you kind of can rule out their setup just straight off that side. When you're doing that model validation, you need to have a place to store those multiple models. I know when you're starting off in a desktop area, that's not going to be that big of a deal because you'll have one person or two desktops. But as you start building out your team, you're going to have to get something up like a GitHub where people can do code sharing, or be able to archive model and version control on model. These things will become important as you get more and more developed in your area. Next step that you go through is kind of that governance and security. Is everybody okay with the model that you're developing? And for those of you who haven't been involved in any model developing, there are many courses that talk about, hey, is your model a racist model? These are things you have to worry about and double check to make certain you're not building something into your model that's setting things up in the wrong path. Once you get past that, they're still okay. Are we okay actually pushing forward the information to the end user that this model is developing? Is this information they need from a PHI perspective? All these things really should be thought out in the business understanding side, but you'd be amazed at how much actually comes up during that governance and security side. Model activation, this is where you're actually first turning your model on in kind of a quasi real-time environment or in a real environment where people are in it. You'll be deploying that model, and then you're actually integrating that model into something like a Salesforce or whatever you happen to work with. That front-end tool for me, a lot of my work goes inside Salesforce. Then what you actually have to record is when that model's running. You can't just let the model run free in the wild. You need to record when somebody's actually doing that process and whether they accepted your suggestion or didn't accept your suggestion. So really, what was the outcome of that? Because what you're going to be doing is tracking that model behavior. Because what a lot of leadership doesn't understand is when you build a model, depending on that model, it might last and work really well for a month, 6 months, or a year, but over time, all models degrade because people change. And as people change, your model's expectations has to change, which is why once you get to that point where you're saying, hey, my model has not reached the level of acceptance or the CSAT score that I'm wanting, you actually end up going right back through this whole cycle again and doing that model testing and development. Nice thing about it is you won't have to do near as much data wrangling or discovering the data source. So it is a faster process when you do that recalibration or resetting of a model. But these are things you have to realize you're going to be doing in your work. And so anytime you build a model, you got to plan time for maintenance of that model in the future and build that into your manpower line. There are tools out there that help you do model maintenance better. But I will say, after reviewing a lot of them, some of them have really good tools, but none of them are perfect. And if you want to talk to me later about vendors, I'm happy to do some of that. If you want to step through. One more slide, please. If you could click the next slide, please.
Am I not clicking to the right slide? This was the next slide.
Okay, yeah, it just got there. Sorry, maybe I have a little bit of delay on my screen. That could be a complete problem on my side. So the next piece, once you kind of have an idea where your what your current state is, and you have kind of your idea of a roadmap, inside that roadmap really should be developing your job descriptions. And when I look at the job descriptions that are out there, you can look at data scientists and what their backgrounds and what people are asking for. Data science, unfortunately, has became a catch-all. You can find data scientists that are paid $70,000 at some companies, and you can find them where they're paid $500,000 at some companies. So you can guarantee the expectations when somebody signs or puts their name in for a data science role. They're not certain what you're asking for, and you're not certain what you're going to get. So you really have to spend a lot of time understanding what your use cases are and put that into the job description of what you're looking to do. I would not suggest particular software you put in there, because if they have the skills in one software, they could transfer over. But I would suggest several types of software that you put into your job description so that you can get people that have skills that what you're kind of looking at. When I look at how you set up the job descriptions themselves, to me, there's a data scientist lead, and I'm going to go through the data scientist lead. There's a senior role, an inferential predictive analyst, and an inferential predictive analyst junior role. And the reason why I use these inferential and predictive analyst terms is because if I just put a general analyst or a data science analyst out there, you end up getting a lot of different things. And for my work, what we really do is a lot of the predictive analytics. We're inferring from a lot of the data, And that cuts out a lot of the noise of people that kind of have backgrounds and that they've been an amazing analyst. They've worked in Excel. They might just have some Tableau skills. They might even have good SQL skills. But if they haven't really predicted anything, I'd rather not waste their time or mine. That's the reason why I kind of chose that sort of title, and it's been very successful. I'll let you guys choose what exact titles you want from that perspective. But that's been very helpful for me. When I talk about that data scientist lead role, the real key to this is you're not trying to find a unicorn in this role. You're trying to find somebody who has a good amount of experience, 7+ years experience in the area you're working on. And you want somebody who can teach the other individuals. And one of the reasons why I call it a quasi-manager role is part of their effort really is spent teaching. There is a little bit of HR side of it, but data science people typically like data science because they don't want to manage people. Don't get me wrong, there's always exceptions to those rules, but they like playing with data. That's what they enjoy. They like solving complex problems. So you want to make certain at least 70% of their time is spent either learning new systems or building new models, because they are your quintessential lifetime learners that always like knowing something new and they like solving problems. When I look for that senior role, I am also looking for someone who has that 7+ years experience. They might not have all the skill sets of the complete data scientist, or they might, but just don't really want to manage people. There's a lot of people who go down this technical side that don't want to manage people at all. They like their individual contributor role, and they also like to kind of coach people on the side. And when it's coaching, it's like, hey, I'm showing you a new technique, or I'm showing you something interesting that you can do, or hey, let me tell you some of the office information so that you understand where data is or which groups that are easier to work with. There's a coaching side that senior does that is really important for the team, and that's part of how I set it up. As you can see, the inferential predictive analyst #1 is really someone who's coming out of school that has probably your master's degree. You're looking for someone who, if they're in a bachelor's, you really want that kind of computer science background. Economics isn't bad, but you really want to have a strong basis in statistics or some sort of mathematical field. A lot of the ones that come out from that area really are, that I hire, are typically master's degree students. I do try, and this is my personal opinion, you can find some diamonds in the rough this way, but try and avoid people that are had a 4-year degree in something that's kind of not in the science area, who's just done a 2-year master's program. What I found is they understand, but they haven't quite grasped the tooling yet. But that's you have to interview those people individually, in my opinion. The second level is really to give those first, because one of the things people do in this role is they're trying to get experience when they first come in. They want to get that 3 to 3 years experience so that they can move on the next role. If you don't have that growth path for them to go to a second level analyst, you're just going to be training people for your competitors. And you really need to have that rolling growth path, which is why I say there's 4 levels in this. And you need to have that ability to move people inside your own organization, because if you don't have that, they will move out. These people like to learn new stuff. They will get bored with the data they're doing if they're doing the same data for 3 years. They want to learn. They need to be able to see that career path. One other thing I would say is, and I spoke a little bit on pay scales, you got to decide what you can afford and understand the skills you'll be getting for that thing. We're in healthcare, so we're not going to be paying that $500,000 for the data scientist role that somebody like Google or Facebook could actually pay. But there are a lot of people out there that have the very good skill sets that fit in that data scientist role and are paid in just, about 130 to 170,000 sort of role. And that is still an amazing set of skill sets that you can capture. If you're looking below that, for like your data scientist lead, you're going to have to look at what you're really asking for out of the candidates. Don't get me wrong, you can find people that just really want to work for your company, and it is a better market now, unfortunately, than it was a year ago at this time. So the market might have decreased. So I would recommend really understanding what the pay scales are in your area, and then what skills you think you want to have, and really have that conversation with HR to build out the right pay scales for these roles. Because if you don't have that, you're going to be spinning your wheels. If you would, step to the next slide. This is my suggestion for organizational structure. And part of this is I develop my data science teams in pods. And those pods I do is, you have a data scientist, and a senior reports to him, and 2 predictive and inferential analysts. And the reason I do that piece is, one, once again, I don't want the data scientists spending a majority of their time doing HR sides. If they're spending all their time doing HR, they're not building the models that I want. Other pieces, keeping that small team gives them the ability to rework with people again and again, and they feel that camaraderie. So team fit is extremely important. If I have two predictive and inferential analysts, and I'm hiring for the data science role or the senior role, I make certain they're in on the interviewing process. And if they don't work well with it, you don't want that person on your team. You either start another team if they have such amazing skills, or you don't actually hire that. If you don't have good fit between the people, you're not going to get that coaching and learning environment you're going to get to develop those junior employees. The other piece is, when I do my budgeting process, I budget by teams, so by those little pods, as opposed to, hey, let me add 1 or 2 more predictive inferential analysts senior. Because what will happen if you don't budget by kind of a pod setup is you'll end up with more and more people reporting to one data scientist. And at the end of the day, they'll either be tired because they're doing all the HR stuff, or when you actually split off those people to another pod, they'll look at you and go, what did I do wrong? So when you're looking at this, you really want to be able to group them into pods, at least in my opinion. Next that I would say is, as part of that interviewing process, I do have cross-team into the interview process. So I might bring the data scientist and senior in on the interview for the other team. And part of the reason I do that is data science is something that you can be an amazing speaker on and know a lot of the detail, but when it comes to the actual work, those individuals help me catch people that are great speakers that don't really have the depth or knowledge that you would expect. And all of us have been in on interviews where you interview somebody and they sound amazing, and then when they come to work, you go, oh my God, where was all that stuff we talked about on the interview? It happens to all of us. This helps catch them ahead. The other piece that I would say is, when you're doing your interviewing process, create a standard test for each role. And a test for the level 1, a test for the level 2, a test for the senior, and a test for the data scientist. And each one of those tests obviously should be a little bit more complex for each. And I say that because you're going to find people, especially if you're looking for particular skills, people might have exposure to those skills, but they may not have the in-depth knowledge, and this will help you catch a lot of those things. And I would say one thing to make certain you do is get the test looked at by HR, make certain they're approving it, and use that as a standard process, so you can't pick some employees and not, or some candidates and not other candidates. Everyone should be filling out that same test, but it will give you a background. And don't include just pure data science questions on that test. You ask for other mathematical concepts. One of the things we ask for is Fibonacci number sequence. Complete this next step. Basic SQL things where you're asking people, hey, here's a population of male and females with test scores. Write a SQL statement, an R statement, a Python statement that divides this and gives me the top 5 for males with the highest score and top 5 for females with the highest score. just to see if they know how to code that information, because those are basic joins and techniques. And you want to be able to see they can do that on the fly. Also give a time frame. From our perspective, we've been doing most of our interviewing virtually at this point in time. We do not require they don't look at their computer, don't look at their phone, any of those other things, because when it comes to any true work you're wanting in data, it's not that they know all these things off the top of their head. It's that they can find the answer and actually do it. And that's what most of their work's going to be in the future. So when I say set up that test, it's important to give them that flexibility to answer it. But you don't want them to take 3 hours to take the test. Plan it for about 30 minutes so that, you know, some of it they do have to know off the top of their heads. If you would jump one more slide. Last, you are never going to be able to do everything with a centralized team. There are too many areas, especially if you have a large company that have demands. So you need to make certain you're spreading the data science skills. Hold educational seminars for leadership so that you're constantly helping them on the data literacy side, and that's really the target audience for that. And then second, create kind of training camps for internal analysts that are interested in it. And this is like for my particular area, we train people on R. And so we run through a wave every 6 months of training courses that we're training people on R or training people on Python. And we go through training courses. I would not recommend developing your internal training courses. There are several organizations out there that offer online training that steps people through R and Python, and you can have your team go through on a weekly basis. And most of them are less than, you know, $400 a year to have an individual signed up for, which is very inexpensive. I say $300 because that's the deal we did, but I don't want to necessarily commit, you know, everybody looking for that $300 one. One thing we do is make certain that people are committed to this learning. So not only when we set up the camp and training, we look for volunteers, but then we also have them sign and say, yes, I will commit to this next 26 weeks, as well as their leader committing their time to the 26 weeks. And for us, we do a mix of, you know, you're taking some of your personal time and some of your work time to get this work done. And let them know it is a commitment of something like 4 to 6 hours every week to get this work done. And at the end of the course, well, actually along the way for the course, some of these online courses actually score and give results and say, hey, this person's really getting it, or this person had to have 15 hints before they get it. And so they get different points. Reward people that have the highest points. Give that, you know, ongoing thing. 26 weeks is a long time to go before, you know, seeing the end of the tunnel. So reward people along the way, and that everybody that completes it, make certain you reward them. I will say we're sitting at around a 70% completion rate for this. And honestly, I still consider that a very good success. We'll go one more slide, please. I spoke a little bit about this as far a little bit earlier, but that Center of Excellence for Data Science is a key place. One is you'll find out who's interested across the organization in data science and analytics, because they'll be asking to be part of the Center for Excellence, or they'll be bringing ideas to the Center of Excellence. That Center of Excellence really should be reviewing vendor proposals. My group's looked at things from finance, we've looked at things from supply chain, we've looked at some of the stuff that's coming from the clinical side. We've looked at things from the marketing side, and we'll look at all those things to say, hey, this is something, we can't do internally. Go forth, conquer. If you can justify the budget side of that, go forth. We've also looked at other things and gone, you know what, this really isn't what they're selling you isn't worth the code it's written on. And we've also looked at other things and go, you know, yes, I realize they're offering this, but you can make a decision. We can build it in this time, or you can try and do speed to market with the vendor and at least give them options. The other piece is that standard list of tools to be used and maintained. There are so many data science tools out there. You need to create a corporate supported set of tools. For me, it's kind of R and Python are the first two, and then our main data science tool is also in there. And there are many other pieces that are out there that people can use, but you want to know which ones you're going to be doing training on and which ones you're going to be the group that's called when it goes down, or if your IT department's willing to be called when that tool goes down. The other piece as a part of that center of excellence is you do really want to create kind of that monthly call for people to review their projects and have opportunity to cross-pollinate between teams. As you get more established, that will be less important for the cross-pollination, because the teams should know each other and know who to reach out to, whether that's the senior or whether that's the data scientist, or whether that's just their friend who might be an inferential analyst if they're working from a citizen data scientist role. But what will become more important than that cross-pollination will be that review of successful projects. You want to highlight those things and make certain you're almost keeping them like elevator speeches to then go to upper leadership so that they know what's going on. I think I've stressed this a bunch, but I would start with open source software. Buy the tools when you need them. Realize it's going to take you somewhere between 3 and 6 months to stand up any sort of large new tool. So do your timing appropriately, but your use cases should justify the ROI. And when I say a return on investment, it's somewhat tricky to do the return on investment of something you're predicting to help in the future. But if you can sell the vision and make certain show that you're being judicious with the money you're spending, you'll get more flexibility from your leadership on that side. If you would, step to the next slide. Okay. Lastly, plan to grow. Data-driven businesses don't come overnight. I think all of you guys have realized this. If we could all do data-driven businesses, we'd apparently, according to research, we'd all be making 60% larger margins, but it doesn't happen overnight. It's one of those things that takes time to grow. And if I've read my latest statistic that I've seen is only about 5% of businesses are data-driven. That's not healthcare. That's across the board. And my guess is a majority of them are kind of your Google, your Facebook, really IT heavy organizations or very customer service driven organizations. But the data driven businesses don't come overnight. You do want to think about what you're building year after year and think about the span of control and where you're actually creating more influence. You might not actually have any span of control on any of it, but you want to make certain that influence through data governance, through data literacy is actually spreading out across the organization. Data governance will be key, and it's a whole, series of steps you have to do that we're not going to discuss today. But if you don't have good data governance and you haven't started the plan for building out the data literacy, you're going to end up with stalled along the process. I would say one of the second keys of the plan to grow side is you are going to grow your team, but if you can grow the skills of other people's teams, meaning through that data science training that we spoke about earlier and developing those internal resources, you're going to get a lot more dividends from the organization. And I say that is they're going to talk about, hey, we've learned this great new tool set and this is how I've applied it and this is the data science work that we've done. And they will be willing to share that information. And it won't be so much of a competition for resources as much it is they see, hey, they're not just growing something that's eventually going to take me over, they're growing my team skills as well, because you can't do everything inside your own team, and you're going to need them to have those skills to build out future data science work as well. You're going to want them to be utilizing the tools that you're standardizing on, because those tools cost money. So if not just your team's using those tools and every other team's, it's a better justification for the tools. It's also when budget time comes to the businesses maybe turn south or margins went, you're not just one big line item with a bunch of very expensive tools that can cut off, because everybody else is also utilizing those tools as well. It's a little bit of a safety net, and they can also see the value to the organization, not just from you, but what you bring to other teams. Growth will really depend on your success and use cases, but it will, the faster you get those successes, and that's part of the reason why I say choose things that are 3 to 6 month timeframes, so that you can constantly get that success rolling and build that momentum. I think David Ramsey, who does a lot on financial acumen for people, preaches this statement where you don't pay off the highest interest rate one first, you pay off the one that's the lowest balance, because it actually gets you more momentum in your own mind. Think of it very similarly. It makes very little financial sense, but it makes sense from a corporation and human perspective. If you can build momentum through those smaller projects and smaller wins, it gets you much faster knocking out the big wins than if you just tried one big win and after 2 years you were able to develop it. You might get cut or slowed down before that 2 years is ever complete. With that being said, I am going to the next slide, and any questions that might actually be out there.
Thank you, Michael. That was great. I will tell you that I wasn't sure about what Kubernetes was, so I Googled it. I looked it up. I'm going to show. Can everyone see that? Can you see the screen that I just pulled up? In case anybody else didn't know what that was, it starts with a Kuber. So I just wanted to, you know, I might be the only one who has never heard of it before, but just in case, I thought I'd share that.
I doubt you're the only one on that one. Yeah, it's been around for a while, but it's became more and more popular in software design recently, because you know how when you start up Windows and they tell you reboot,
yeah,
because something jammed up, this allows you to restart up a whole nother program real quickly, or keep multiple versions of the same program open and just switch between different environments. So it's really powerful, and it's something that's going to probably change most of how we set up our software architecture in the future.
Oh, great. Well, we do have some questions. The first one says, what tools are used for statistical analysis, mainly model building? And
Okay.
so there's actually 3 questions, but we'll take one at a time for this particular person.
So for basic statistical analysis, you can use a whole slew of programs. Most of your basic SAS or SPSS, R and Python do some statistical analysis that you can look in through, and they're actually pretty good tools from that perspective. MATLAB's another one from a statistical analysis. From a model building perspective, I actually prefer R and Python. That seems to be what most of the analysts out in the market are utilizing today. And if you're trying to go down if you actually even look at the vendors such as IBM or SAS or DataRobot or any of the other ones, they're actually just integrating those open source tools into their product as their kind of their future, because for the most part, if you're going to build the models and the tools that you have the skills available in, and so to me, it's R and Python. What was the second question?
So the next question is, does THR use any of the predictive models in Epic?
So no, not right now. Well, not from my team. Let me say that right. There are predictive models in Epic that our clinical informatics team has built, some of them utilizing information we have, and some of them utilizing some of these standards predictive models that come out of Epic. I actually look at the clinical workflow and say, you know what, that's probably not the area I would start a data science team in. And part of the reason for that is, one, if it's pretty easy to predict, you're probably telling a physician something he already knows, or a nurse something they already know, and you're just throwing a pop-up that's more annoying. Or if you're telling them something that maybe is a little bit more harder to discover, getting approval to push that in through the workflow typically, or building it into Epic, is going to add about 3 to 6 months to your timeline of implementation. So from my team's perspective, we've stayed a little bit away from that. But from the clinical informatics perspective, they've been building this.
Okay, the next question we have is, who presents the work to the executive? Do you work with business or SME teams? I'm not sure what SME stands for.
Subject matter experts.
Okay.
So when I do new predictive models, one of the first things we do is we have levels of data governance. And I'll typically have the analyst kind of present that idea at the first level of data governance, which we call our operational team. And they'll also present at that Center for Excellence side. And the operational team is essentially all your analytic directors or senior directors across the organization, a couple of VPs that are in that meeting. And if they, depending on their skill set in presenting the information, will move that same presentation over to PMAT, which is more of the more of the VPs across our organization. And PMAT for us is like the second level of data governance, where you go to if you need prioritization that can't be decided by analytic leaders. And if the third level for data governance is if they don't, if there's too many things to prioritize and they said, hey, these 12 things we need to go to, but we need resources for the last 3, go to STT. And so when they're presenting at the first level of data governance and the operation group, we kind of see how well they present, and then depending if they, how their speaking skills are, we might actually have their manager speak at the next level, and if depending on their speaking skills, it might be their VP who speaks at the STT level, which the STT level for our organization is like our CEO and the top 7 people in the organization. Most of our data science work doesn't ever reach that level. They hear about it, they understand it, but they don't want the details as much. They just want to know the outcomes. So from a perspective of, we try and get the analysts to present themselves, at least at the first 2 levels, but we might move to their manager depending on the individual speaking skills.
Okay, great. Another question that we have is, if there are several data resources that could possibly work for what you're trying to build, how do you vote on that? Is it the data governance committee that votes on that? How often is that committee meeting to decide what the resources are going to be?
So when you mean data resources, are they meaning analysts, or are they meaning?
I think they're meaning the actual data, like when you're trying to figure out what data, like are you using internal data? Are you going to have to purchase data? Maybe there's more than one option to purchase.
So, okay, there's a lot of questions in that one. From a data source perspective, typically what we do is we have the analysts look through the data themselves, so they'll get access to both sources, and they'll let the models themselves tell us which one's more predictive or not. When it comes to buying outside data sources, we typically look for things that are a standard package we can purchase, whether that be through Experian or whether that be through IXI or another vendor. That's typically not controlled at kind of that analytic level. That's controlled more at the PMAT level or the need of the particular area. Most of the Experian data we purchase is due to our marketing department wanting it, and we merge that into our traditional data sets. most of like claims data that we might want to see around the area, that's controlled more by our strategy department that's trying to figure out, hey, are we losing volume, gaining volume, or in comparison to our peers, and then they're actually purchasing that. That's not typically controlled by the project itself. It's controlled by kind of a general use statement. Access to that data is controlled through governance and stewards over that data. And as long as you have a legitimate use case that meets compliance gathering, it's very easy for us to turn on your access to that data or turn it off.
Okay,
I hope
great.
that answered the question.
Hopefully it does. So I want to thank you for your time today, Michael. Great presentation. Again, lots of compliments on all our presentations today, and thank you to all of our panelists who presented throughout the whole conference. And again, one more time, I will upload everything. I'll let everyone know when I've uploaded everything, and I'll send out the link to do the survey for your CNEs and HIMSS CE if you're wanting that. And if we have no other questions, I think that we have wrapped up our fourth successful conference, and I appreciate everyone's patience as we work through doing a virtual conference and everyone's attendance. Thank you so much, and we hope you have a great weekend.